Invite Dr. George Puthuran to talk on post-trab glaucoma progression. So repeat trabeculectomy or GDD.
Thank you, Dr. Girija, and thank you, KSOS. It's always nice to be back in the home state. So this is a survey by the American Glaucoma Society, where they gave their members a survey about the use of different glaucoma procedures in various clinical scenarios. They did it in 96, 2002, 2008, and finally in 2016. And they found that out of 7 out of 8 clinical scenarios in 2016, GDD, the uptake of GDD was more than a trabeculectomy. In a setting of repeat patient who has had a failed trab, till 2008, repeat trabeculectomy and GDDs were comparable. But in 2016, you can see it's GDD has overtaken a repeat trabeculectomy as the procedure of choice in a failed trabeculectomy. In 96, there was not a single response for GDD, but almost 70% of responses were for GDD against repeat trabeculectomy in failed trabeculectomy. So this is a very interesting article about clinical impact of 8 prospective randomized multicenter glaucoma trials. This was also another survey where they independently, this was not the TVT group, they independently concluded the results of the TVT study likely contributed to the shift to GDD rather than repeat trabeculectomy in eyes with previous failed trabeculectomy. So as of now, we just have this prospective randomized clinical trial to comment on GDD versus repeat trabeculectomy in a patient who has had a failed trabeculectomy. The study group took patients who have had phacoemulsification and or filters, and then they randomized these patients into one group will get a trabeculectomy with mitomycin, the next group will get a Bowell 350 implant. This is actually the stratum 3 and most importantly the stratum 4 in this group is very pertinent to the dilemma we are discussing today. But the sad part is they had very few patients here to draw conclusive decisions. There are a lot of things which came out of the TVT study. They said tube shunts have a higher success than trabeculectomy with mitomycin. They said tube shunts are associated with a lower rate of early complications compared with trabeculectomy with mitomycin. They said tube shunts have lower resurgery rate when compared to trabeculectomy. I totally agree with this. Tube shunt surgery is less labor intensive. The number of the shepherding required for a post GDD is less than a trabeculectomy. And they also challenged certain established facts. We always thought trabeculectomy got the pressures down to very low teens. In the TVT group, they showed that about 62% of the patients had a mean IOP of 13 millimeters of mercury at 3 years. This is another scenario. It's a phakic eye. Already a trabeculectomy has failed. A second glaucoma procedure is definitely going to induce cataract. There's no doubt about it. So, and there's a lot of literature says that cataract surgery, trabeculectomy, usually the control of intraocular pressure is much less. Trabeculectomy starts failing after cataract surgery. May not be so with tube shunts. We also have published on this a set of patients who had underwent our Orolab aqueous drainage implant. We looked at their pressure controls. Thankfully, it was maintaining even post-cataract surgery. Again, conjunctival manipulation can increase fibroblast production and increase chances of failure. So why again why do a trabeculectomy again in a failed trabeculectomy? So all what I said, it looks as if it's a hands down victory for tubes, but actually that is not the case. That is why we're having this debate. A very interesting publication in which it is written, the tube versus trabeculectomy study, why its findings may not change clinical practice. They have given very clear points to ponder on. They said universally the lower IOP, till now the literature says is more with trabeculectomy. High rate of complications in the trab group in the TVT study may not be for all others, because the present literature says the complication rates are not as high as in the TVT study. In the TVT study, they used 0.4 milligram ml of mitomycin for 4 minutes in all their patients. There may be motility problems associated with the bowel, relatively short follow-up. Need longer follow-up to see whether tubes erode in the long term. Every patient in this group had a prior intraocular surgery. They say you cannot extrapolate this to other tube surgeries. And most importantly, as was Dr. Satyan was mentioning, established practice is difficult to change. I looked at literature to search for outcomes of repeat trabeculectomy, and it is sparse. It is not as much as what you would do with what you would get with the primary trabeculectomy or with the tubes. But I found two interesting studies. One was this study in which they had almost 75% success, qualified success at 5 years for a repeat trabeculectomy. But I also had I saw a publication. It added more to the confusion I had. Here again, they compared a group of patients who underwent repeat trabeculectomy with an age-matched group which already had an initial trabeculectomy, and they saw that outcomes of repeat trabeculectomy were not as good as the initial trabeculectomy. So this was about 50% qualified success. Much closer home, Shankar Nethralaya group has shown that repeat trabeculectomy with MMC is successful at lowering intraocular pressure and decreasing number of anti-glaucoma medications. And the icing on the cake was my own colleagues in my own department has very clearly written that repeat trabeculectomy with mitomycin used in higher concentration exposure time altered according to individual risks plays a crucial role in the success, and they say you should not abandon this procedure as a viable option before you try a tube surgery. This is a slide which I showed 12 years back in one of the World Glaucoma Congresses, where the same dilemma, we were discussing the same issue. And I feel the only thing that has changed over the past 12, 13 years in this topic is probably the color of my hair. Choice is highly individualized. Most important thing is how long did the first filter work? I think Dr. Satyan always used to tell me more than 5 years is a reasonable justification to consider a repeat trabeculectomy. Your filter has worked for 5 years, it's a reasonable justification to consider repeat trabeculectomy. POEG with failed filter, phakic or pseudophakic, especially if the pseudophakia is a clear corneal phacoemulsification, I would leave it to the surgeon preference and experience with either procedure. Type of glaucoma is a secondary glaucoma with a failed filter, almost always tubes. There's also evidence from the TVT and the primary tube versus trab study, which says higher presenting intraocular pressures do better with tubes and lower presenting intraocular pressures do better with trabs. I would like to go one stage ahead and say high intraocular pressure, advanced ONH and visual fields, probably tubes may be safer because the risk of hypotony and choroidal detachment and effusions are more with trabeculectomy. Advanced PACG, I will be adding to the confusion here. Advanced PACG, phakic with a failed filter. Believe me, surgeons are probably now shifting to mix in these kind of patients only for the safety profile. We don't expect a lot of efficacy in this, but if there's a little bit of incipient cataract, if you can do a mixed procedure with cataract in this setting, aided by goniosyneculasis, probably that would be much safer than a repeat trab or a tube. Again, advanced PACG, pseudophakic with a failed filter, tubes are an option and the pressures are very high. You could try a diode CPC to tamponize the pressure temporarily before going for a tube. I can already see Dr. Girija's IC in KSOS 22-27, post-trab glaucoma progression, repeat trabeculectomy or GDD or mix with cataract surgery. TVT study does not demonstrate clear superiority of one glaucoma operation over the other. Believe me, doing a repeat trabeculectomy and getting it to work, I believe needs as much a skill as trying for a tube, as doing a tube, and prefer to use valved implants, non-valved implants, because valved implants are sometimes very unpredictable. And in our hands, these are the scenarios where we prefer a valved implant: NVG, uveit glaucoma, elderly patient. Thank you very much.
Thank you, Dr.